Good morning from Nashville, Tennessee. I would like to thank the conference committee for the invitation to present for all of you today. I'd like to disclose the research I will discuss in this presentation was done at Vanderbilt University Medical Center in our perfusion simulation lab and is reflective of the research completed in our perfusion program to support the ability to grow our student enrollment and to use simulation to maintain the quality of our clinical instruction in our student body. I do have to disclose that I am a member of the Speakers Bureau for Biomedical Simulation. Vanderbilt University Medical Center is located in the heart of Nashville, Tennessee. Annually, on the adult side, we perform over 2,225 procedures, with 1,100 of those being on pump. And our pediatric service performs over 325 cases, with 275 of those being on pump cases. The objective of this discussion will be to provide you with a brief historical view of simulation, with the vast majority of my presentation discussing the application of simulation in the educational process of perfusion students and the impact it has on their clinical readiness. The discussion will include a quick view of some team training that we do here at Vanderbilt in our cardiac surgical fellowship program. And we do a multidisciplinary curriculum with that training. So what is simulation? Dr. Gaba from Stanford University, known as the father of simulation, describes simulation as a technique, not a technology, to replace or amplify real experiences with guided experiences, often immersive in nature, that evoke or replicate substantial aspects of real world in a fully interactive fashion. The earliest recorded use of simulation was done by the Roman Empire. Their simulation scenarios began by utilizing tree trunks for soldiers to practice their sword stroke on foot and evolved to simulated practices in boats and on horseback with the development of a 6-foot wood figure of an armed enemy. Simulation is utilized today heavily in our armed forces. Simulation is used in all aspects of military training and has advanced significantly since the Roman Empire introduced simulation. Soldiers are gaining not only operational training, but combat training through virtual reality. This allowing the soldiers to actually perfect skills before they get into combat. Aviation really became the industry leader in simulation with the first flight simulator introduced in 1909. This simulator was an upturned dome on a pivot that was kept horizontal by a pulley system, which was manipulated by two instructors to simulate the pitch and roll. The first real application, though, came with the Link trainer, also known as the blue box, or the pilot trainer. It was introduced in 1928 by Edwin Link after receiving his pilot's license. It differed from what the first simulator was in that it had a pneumatic platform driven by a bellow system. In 1930, Mr. Link opened his flying school, and his simulator allowed him to provide students with a safe and less expensive way to learn flying. In 1933, the Link trainer was upgraded to simulate instrument flying, and it was a series of highly publicized fatal crashes due to bad weather and inexperienced pilots that caused the U.S. Armed Forces to recognize the potential benefits of simulation, and they ordered 6 trainers to improve the pilot's skills. During World War II, 10,000 pilots were trained using simulation. On the left, you can see a modern flight simulator, and on the right, the cockpit of that same simulator. This simulator is used today by pilots to complete their required simulation training twice a year. The simulator that logs these hours must be certified by the FAA for pilots to receive credit for those simulations. In early 2014, the FAA had cut the required simulated hours to 10 hours, but then in May of 2016, the FAA reverted back to 20 hours of those 40 hours of instrument training could be performed in an approved flight simulator. So they found the benefit of simulation. So when you look at simulation in medicine, how has it evolved? Dr. Gaba described 5 categories of simulation in medicine. The first being verbal, which involves role playing, where the learner acts out an occurrence. This type of simulation is relatively low in cost and can be very beneficial in team training. The second being standardized patient, which utilizes actors to educate and evaluate history taking, physical examination skills, along with communication and professionalism. This type of simulation can be found to be beneficial to students in gaining an understanding of their strengths and weaknesses with regards to their ability to communicate, and also it assesses their awareness of how they react to stressful situations. The third type is part task trainers, which are simple anatomical models of body parts in normal and disease states. The learning objectives of these simulations are very task specific. The advantage of this type of simulation is that it is standardized, portable, and tests a specific skill, similar to what we see in our BLS training. However, this type of simulation really lacks realism. The fourth being computer patients, which are interactive and may be software-based and can serve as a standardized patient in many areas of learning, which has been shown to reduce the cost of education. The fifth being electronic patients, which can be mannequins, virtual reality platforms, hydraulic units, or a combination of all of these, but that is immersed in an environment that replicates the surgical environment. This has been shown by evidence to increase clinical readiness. So how has medicine embraced simulation? Medical simulation really owes its roots to our anesthesia friends, which was the first group of physicians to implement this new modality of learning to its residents. And it has evolved the technology to its members of its professional society through the use of simulation in their recertification process in hopes of reducing medical errors. What about perfusion education? Currently, there are 16 accredited perfusion education programs in the United States, coming in the form of certificate programs, bachelor's programs, master's degrees. The duration of these programs range from 12 to 24 months. Perfusion education programs are accredited by the Commission on Accreditation of Allied Health Education Programs upon the recommendation of the Accreditation Committee on Perfusion Education. Each program is required to deliver the consensus curriculum as outlined by the ACPE. All programs are required to get their students a minimum of 75 clinical cases in which they are the primary perfusionist prior to graduation. In addition, they are required to have 10 pediatric observations at a minimum. The guidelines currently state that simulated clinical experiences should be incorporated into the curriculum. So it's currently should be. However, there is a new proposed guideline to change the clinical instruction in which simulation is used. The new guideline that is proposed states that instruction must be in an appropriate sequence of classroom, laboratory, and clinical activities that include clinical experiences. And these clinical experiences that are in a laboratory setting are recommended to be in a high fidelity simulation situation. So when we talk about that, we need to understand the different types of simulation. What is high fidelity simulation? And literature describes 3 types of simulation. Low fidelity simulation, which is focused on single skills and permits learners to practice in isolation. So some of us may have learned with a bucket and the pump, a bucket of water and a pump. Medium fidelity simulators provide a more realistic representation, but lack components for full submission into the scenario. Whereas high fidelity simulation provides key components for full submission into a scenario. It allows the opportunity to apply appropriate treatment modalities And those modalities are responsive. So you see a cause and effect relationship. So when we look at learning techniques, it's often that we go back to this pyramid, right? The learning pyramid. Historically, most of our teaching in perfusion has been in a classroom setting where we involve the student in what we call passive learning, listening to a lecture, looking at PowerPoints, or reading textbooks. From evidence, we know that this type of learning leads to 5 to 20% retention of that material. The student then would enter the OR with their book knowledge, which has been shown to have limited retention, and would be asked to pump cases or prove their ability to pump a case. The clinical curriculum is solely really dependent at this point on the patients that randomly present and the ability of the student to earn the confidence of their clinical instructor. Research has shown that learning by doing drives greater retention than other learning methods. Simulation is a teaching methodology or a learning platform which allows the student to learn by practice and can incorporate group discussions. This avenue of learning has shown a 5 to 75% retention of the skills taught in those sessions. So when you look at simulation, really what are the benefits of simulation? And in our opinion, and in what literature has shown, it allows a student to gain an understanding of when a wrong occurs and why it has occurred. And this all can happen in a safe environment free from harm to a patient. Simulation allows for repetition of low frequency events and allows a student to come upon mastering those, or at least having the ability to do those low frequency events. Simulation promotes an open culture. It promotes the ability for students to talk with the physicians in our team training. It allows an environment where there's less blame, more accountability, a reduction of hierarchy. The students can learn from the surgeons, and the surgeons can learn about the operation and the management of the heart-lung machine. Simulation provides the ability of the trainee to apply knowledge to treat patients in a real clinical setting without compromising the patient. And more so, it allows the clinical instructor in those simulation sessions to focus on the trainee. There is sole focus on the trainee in these sessions. There isn't an actual patient that needs to have the priority of the clinical instructor. Simulation provides us with an avenue to challenge new techniques and technologies in an environment that will promote that learning curve. We can analyze new techniques. We can look at new oxygenators, new management processes. So how do we use it? Simulation has proven in history through military training as well as anesthesia training that it is a very prevalent way to educate students. Medical simulation for students in training helps bring real life scenarios into the simulation lab, which promotes practical learning in a safe environment with the ability for the students to have some type of remediation. What we do at Vanderbilt is we have a simulation curriculum, and we start out with really basic skills, learning and mastering basic perfusion skills. We then move on to practicing emergency and uncommon events. We have at least one practical examination a semester in the simulation lab where the students are required to show competency in certain skills and be at level for their pace. We have used our simulation lab in the form of remediation. When we get back clinical evaluations from a student, from a clinical instructor, that they have found the student struggling in areas, we'll bring them back into the simulation lab, take them out of clinic for a week or 2 weeks, and really just focus on honing that skill in that student. We have used our simulation lab for interdisciplinary team building, ECMO training, cardiac surgery training. We do research, and of course, our simulation lab is used to promote recruitment and keep up with other perfusion schools across the country. The VUMC simulation lab does include a heart-lung machine, a SARNS 8000. We have our CALIFIA, we have a heater cooler, we have hemodynamic monitors, we have interaortic balloon pumps, and this is what our simulation lab comprises. We use the CALIFIA. We have a patient module, and it's considered this blue box. It is comprised of tubing and a reservoir system with several transducers attached to a Windows-based laptop computer. Information from the patient module, such as bypass blood flow rate, cardioplegia, the circulating blood volume of the patient, is all communicated back to a main CPU. This information is driven on a separate monitor, which serves as the OR monitor and displays typical hemodynamic monitoring, which you'll see here. So if you look, this monitor here is what the clinical instructor or the simulator facilitator would control. This monitor is the hemodynamic monitor, and the students would control the sweep gas from here. They can also call for blood gases. They can monitor their heater coolers from this screen. So this is what is utilized, what we consider the student hemodynamic monitor. Over here is where we do all of the scenario changes. We can change venous occlusion. We can create an arterial high line pressure. We can modify the ability for a student to give retrograde cardioplegia, either it being back into the right atrium or too far in. So you can see there's a lot of things that can be done with the simulator. The instructor can alter the patient's SVR, contractility, heart rate. We can alter lung function. We can simulate blood loss into the pleural cavity. We can hold that volume up. And we can wait for the student to ask for that volume back. We can change the route of delivery based on the procedure. We can create the inability to arrest the heart and walk the student through the algorithm of the things to look at when you can't arrest the heart. We can simulate obstruction of a kink or a completely occluded arterial line, acute dissection. We can simulate air in the venous line and venous chatter. What you see here are conditions that we would change for a student pretty early on in their clinical training. Within that first semester, all of these scenarios would be created within the last 6 weeks of their simulation in the program in their first semester. So our curriculum, in designing the curriculum, we really had a goal of bringing the classroom into the simulation lab. So a typical simulation session could last up to 3 hours, depending on what skills we were trying to teach the student. Up to 3 hours we would have, and we usually have 2 students. So you would have a student watching while a student performed, and then vice versa. And we really found that students learned a lot from watching each other. In our sessions, we usually start out with what we call a pre-brief. And in that pre-brief, what we do is we'll really look at discussing the calculations for the case, the pathophysiology, and the pharmacology, things that a student might do the night before the case. And we really review pharmacology. We ask about valve sizes. We ask about normal heart chamber pressures. We talk about pharmacology. Then we get into the briefing on the scenario. And that briefing of the scenario is very similar to a timeout. We discuss cardiopulmonary bypass management, and we allow the student to tell us what the cannula should be for the case. We talk about myocardial protection, what our target hematocrits are. And then we move through the session. Most of the time, a session is very task specific. So we might just be focusing on passing lines or wrapping that day. And what we would do is just perform that task, look at that task. We might do it multiple times in a session and get them to really perfect their skill. We then have a debriefing, and the student is given an assessment, and the students are asked to reflect upon their session. As we move through the curriculum and the weeks of simulation, we repeat the previous task while adding on to new tasks. We add new tasks to build knowledge, and we focus on the previous tasks to help build their confidence. The debriefing, again, will incorporate what they did well and what wishes we had for them to improve upon. We also might go back and do some demonstration of a skill they did and describe how their technique could be improved or how we like their technique. Finally, in our later parts of our program, when the students move into their senior year, we really advance the simulation curriculum into what we consider low frequency events, such as oxygenator changeouts and different low frequency events that we'll see. So beginning simulation, we want to see the students demonstrating the ability to integrate circuit design, the things that they've learned in the classroom. We want to see them competent in priming a circuit. At 6 weeks into our program, students are asked to prime a circuit, set up and prime a circuit within 20 minutes. And that is a practical they are given. We consider that their midterm simulation practical. We look for students to demonstrate the ability to perform fundamental cardiopulmonary bypass management skills, passing lines to the surgical table, connecting of cannulas, retrograde priming. These skills we all work on in the next 12 weeks of their simulation curriculum. We ask them to demonstrate the ability to interpret and perform commands from the surgical team. So the simulator has the ability to create 3 voices. And in our simulation scenarios that have been created, we have an anesthesia voice, we have a surgeon voice, and we have a clinical instructor voice. We look for them really to develop a cause and effect relationship and to start having those algorithms in their head incorporated in what we would consider our higher frequency events, low venous return, maybe a surgeon leaning on the arterial line, having high line pressure. And finally, we look for the simulation in these first 18 weeks of their education to really help them gain a confidence in their perfusion management skills prior to entering the surgical arena. Our advanced simulation is then, they're following their first 18 weeks in the program, they come to simulation one day a week. They spend about 2 hours in simulation through the rest of the program. And in these simulations, we're looking for them to continue to demonstrate the ability to perform fundamental cardiopulmonary bypass. But we also take about 9 weeks of that second semester in simulation where we go through all of those fundamental tasks using a centrifugal head versus a roller head. Most of our clinical sites in Nashville, where the students are their first clinical experiences, are roller pumps. So we want to get them some centrifugal pump experience prior to going to what we consider our outside rotations. We also work the last 36 weeks of their time in our program. We look at management of some of the low frequency events. So we move into managing oxygenator supply failure, electrical failure, protamine reactions, air embolisms, and acute aortic dissections. So that is how our curriculum progresses through the program. What we wanted to do at Vanderbilt is really evaluate whether simulation would increase our students' clinical readiness. And in cooperation with our advisory committee, as well as our clinical competency committee, they wanted to see if simulation would aid in our ability to increase our student enrollment. So what we did is we performed a multifaceted evaluation process to validate our newly introduced simulation curriculum. We compared 2 student classes without simulation, in which we had 12 students in that cohort. And in our second cohort was our students that had simulation curriculum. So they went through this simulation curriculum that I just described. And we had 15 students in that curriculum. We asked each clinical instructor who supervised a student in the first year, whether they were in the simulation curriculum or not, we asked them to evaluate the student in the first 5 weeks in their first clinical experience. And we asked them to look at a few things with regards to clinical readiness, their competency, as well as their confidence in communication. We also surveyed the students. And the survey to the students was only to students that were in simulation. So this was kind of an added piece after. But the students that were involved in the simulation curriculum were asked about their experience after 2 weeks in clinical participation. And then the last part of this was that both cohorts were sent midterm clinical evaluations, and they were sent these evaluations at their clinical instructors were sent these evaluations after 10 weeks of a student being in the clinical experience for the first time. And what we were looking to do is gauge the student's clinical readiness. As a program, we look to define what our early goals of simulation would be. And what we defined our goals to be were to use a computerized patient with deliberate practice of specific fundamental skills. And what we wanted to do was reinforce those fundamental concepts through simulation. Our end goal that we thought would come out would be that we would have better clinical rotation experience through the use of simulation, and we would have an improvement in clinical readiness in our students. The overall arching objective of our simulation curriculum was to improve the confidence in our students, improve their communication, and improve their fundamental skills. What we found when we asked those students, so again, we only surveyed the students that were exposed to simulation. I wanted to see how they felt about simulation. And we asked them what their likes were and what their wishes were for simulation. And what they wished for was more integration of simulation in the curriculum. And now these were students that were exposed to 18 weeks of simulation. And they wanted more time in simulation prior to going into clinic. And these students on average had three hours of simulation a week for 18 weeks. So I only can think that if this is what the students wanted that were exposed to simulation, I can only imagine what students that hadn't had simulation would have wanted. What they found that they liked about simulation is they felt there was a lot of realism in the scenarios. They liked the variety of tasks and the ability to move sequentially through the tasks. They liked the ability to master a task, then learn to another task. And they liked the ability to really see the mistakes they made and really learn from that. One take-home message for anybody who's a clinical instructor out there, what they really appreciated about the simulation scenarios, and it was 100% on the responses that I got from the 15 students, is that they liked the immediate debriefing. So if I can say anything to the clinical instructors out there, I can say to you is that verbal immediate debriefing that you have with the students after a clinical case is invaluable to them. There is no price on that. So please continue to do that. The student feedback, what they came back is that they found the most benefit in really having all that time and setting up the circuit. They felt that the clinical instructors saw a lot of confidence in them. They appreciated the ability to initiate bypass for the first time in a simulation lab rather than the OR, which I felt was really good because I felt that they understood the gravity of their role that they play in the operating room. They really liked the ability to understand RAP and to create and to learn from their mistakes in the simulation lab rather than in the operating room. They felt there was a huge link between their cause and effect relationship in cardiopulmonary bypass management. They liked the ability to terminate prior to ever doing that on a real patient. And most of them felt their communication skills were really good, and they felt comfortable communicating in the clinical operating room. So At 5 weeks, we asked the clinical instructors to give us some feedback on the students, and this is what we asked them to look at. We asked them to look at their professional conduct, and really we were looking at their communication. We asked them to evaluate their clinical management skills, and then finally to overall rate the students in their clinical readiness after 5 weeks in clinic. So what we found is we found the communication skills in comparison to classes without simulation showed that 42.9% of them were always had more communication than those of the cohort that did not have simulation. So we do feel that this helped the student in their first 5 weeks being comfortable communicating. What did we find with regards to their clinical skills? The clinical skills identified by the students, clinical evaluations by the instructor showed that simulation did improve them in just about every aspect. It did in the first 5 weeks. And what we found is that the clinical instructors found them to be somewhat prepared and even to lean very prepared. We didn't have too many areas where the students were leading in somewhat unprepared in comparison to the group that did not have simulation. So we did feel that at 5 weeks, our students were clinically ready for clinic as a result of simulation. Overall, what we found is the overall rating of overall clinical student readiness in the evaluations by our clinical instructors showed that 70% of the students in the simulation arm were above level in comparison to our non-simulated arm, where our students were under level, and it was 45 to 55%, so of the students in the non-simulated arm. The real thing that we really were looking at and kind of getting a gauge on was our midterm assessments. So we next performed midterm assessments on each of the classes, and this was done again on both arms, the simulated as well as the non-simulated arm. And our assessment looked at the students' patient workup and CPP game plan. We also looked at their circuit setup, initiation, and termination skills. And we were comparing the two arms, the simulated arm versus the non-simulated arm. So for our midterm assessments, we received 54 responses in the pre-simulation arm and 45 responses in what we called the high fidelity simulation arm. What we found was that in the area of patient workup and cardiopulmonary bypass game plan management, we did see a higher percentage of our student assessments returned in a supervised and independent arm, independent group. So we do feel that simulation did help our students, and you can see that roughly 52% of our students in the simulation arm were in a supervised or independent role in patient workup and cardiopulmonary bypass, in comparison to 85% of the students were in an assisted role in the pre-simulation arm. When looking at circuit preparation skills, we did see a higher percentage of our students' assessments returned in a supervised and independent level in the simulation group. Again, you're seeing about 53% of our students were in this supervised and independent role in the area of circuit preparation when they were exposed to simulation, as compared to 85% of our students were in what was considered an assisted role by our clinical instructors without simulation. Next, we asked about the initiation skills. Again, we did see a higher percentage of our student assessments returned a supervised or independent level in the simulation group. And you saw about 45% of those students being in a supervised and independent role in comparison to 94% of the students were in what was considered an assistant role after 10 weeks in clinic in their initiation of bypass. Lastly, we asked our clinical instructors about termination skills after 10 weeks in clinic for the first time. And again, here we did see a higher percentage of our students, a significantly higher percentage of our students in what was considered a supervised or independent level of termination skills. So what about their entry into the hot seat? We wanted to see if simulation changed the time from when a student entered the clinic until the time they were allowed to pump their first case. And we did find that this was reduced. Why this was significant for us is because we increased our class enrollment. So we went from class sizes of 6 to class sizes of 8. And our advisory committee was really looking to increase our enrollment up to 10 students. And what we needed to show, and what our competency committee wanted to know is, can we retain the same clinical experiences with a higher volume of students? So again, in comparison of clinical days prior to the first pump, we next wanted to look at comparing that first student to pump a case in each class and the last student to pump a case in each class, and to see if simulation could potentially narrow that gap. And why might that be important to narrow that gap? These students spend a lot of time together. If anybody has been involved with perfusion education, students that come into perfusion programs are very competitive. They're usually high achievers. They want to be the best. And so most perfusion programs have the best of the best. And when you do that, you create a very competitive environment, and students can become very anxious about when who pumped the first case and how long has it been since he pumped his case X many days before I do. And it can lead to their anxiety behind the pump. And so we did show that we were able to, through formal high fidelity simulation, we were able to narrow this gap and actually reduce the time between the student getting into clinic and pumping their first case. Lastly, we wanted to make sure that increasing our student enrollment would not decrease the overall clinical exposures that our students got. And what you're seeing here is the number of supervised clinical experience cases on average that Vanderbilt students get. And this is not observations, this is pumped cases. So on average, you can see that our classes average more than 200 cases during their clinical experience, which they pump cases. I can tell you that on average, our students are seeing about 465 clinical cases in their 22 months at Vanderbilt. So we do have a high clinical experience. One word of caution there is that it's not always the number of cases, it's the quality of cases that a student gets. And the quality of cases comes with the patient experience that they see, as well as the clinical instruction that they get. So I really give a lot of kudos to our clinical instructors. They take on a lot. Our students are in a lot of cases, a lot of very high acuity cases, and I am very appreciative to all the clinical instructors out there that have taken on our students and have allowed them and have given them the ability to pump cases with them. So while I do not disagree with critics that simulation is not real, I can tell you that simulation is the bridge that successfully ties a student's didactic training to their clinical training in aspects of introducing fundamental skills of cardiopulmonary bypass by promoting their clinical readiness into an actual clinical environment. So onto some team training that we do at Vanderbilt. Each academic year, we take on about 2 cardiac fellows, and we have created what we call a cardiac boot camp. And that cardiac boot camp entails an entire month of what we call submission into the clinical simulated environment. During that time, our cardiac fellows are exposed to cardiopulmonary bypass management, in which they run the heart-lung machine. They're exposed to different low frequency as well as high frequency events of cardiac surgery. They are exposed to communicating with perfusionists, anesthesiologists, and we run this course 8 hours a day for 4 weeks. And it does incorporate interdisciplinary training with cardiac anesthesia fellows as well as perfusion students. The objectives of this boot camp, what we call boot camp, is for the cardiac fellow to demonstrate competency in the independence in management of routine clinical scenarios. They also manage cardiopulmonary bypass, so one fellow will be operating with an attending while the other fellow is running the heart-lung machine for about 3 days a week. 2 days a week, we have students running the heart-lung machine in those cases. They demonstrate task-specific competencies in relationship to cannulation, initiation. They do coronary bypass grafting. They do aortic valve replacement, root replacements. They do termination of cardiopulmonary bypass, and they work through all of those scenarios. This is what we use. We use a bovine heart, and it is beating, and I'm going to show you that here momentarily. This is the beating heart down in the bottom that we use at Vanderbilt. And it was created with Biomed Solutions. This is our beating heart, and you can see that the heart actually beats. That's a bovine heart. We put 2 balloons into the right and left atrium, and that works in sync with the EKG. Down at the bottom there, you're seeing this is what this prep was for an acute aortic dissection, so that's a femoral artery, and the surgeons are then allowed to cannulate femorally. This is just an example of communication. And now I'd like to show you some team training that we do at Vanderbilt. Oh, let me go back. Sorry, my bad.
One minute left, Nikki.
Okay. So this is a team training that we do, and there's multidisciplinary professionals here. You'll hear a perfusion student. You'll also have the surgeon. I'm going to see if I can speed it up a bit. We're gonna, it's an off pump that we're gonna then crash on bypass with.
Thank you, Nikki. We're going to have to move on. I'm so sorry.
Okay.
This is a great video here.
So I can tell you one last thing, that simulation really has been proven through evidence to show that about half of your clinical hours can be substituted with simulation experiences. And this was a randomized control trial that was done by the Nursing Society to show simulation can be used.
Nikki, thank you so very much. I'm sorry I had to cut you off there. We were trying to stay on time. That was very good. There's a lot of questions on the webcast for chats, for a lot of questions for you. So if you can take time to visit those and answer their questions offline, that would be absolutely wonderful. Thank you so much, Nikki.
You're welcome.
Great job.